Welcome back to the Deep Dive, where we cut through the noise and deliver the core insights from the most complex research tailored just for you. Today, we are wrestling with a really troubling paradox. It's right at the intersection of public health and public safety.
Yeah, that's right.
Our source material focuses on people with serious mental illness. So we're talking specifically about schizophrenia, bipolar disorder, major depressive disorder, and here's the observation that just jumps out.
It's pretty stark.
Despite a the sources say prolific number of programs designed to divert them away from jail and into treatment, this population is still wildly overrepresented in the criminal legal system.
It's a massive policy challenge, isn't it? I mean, if decades of investment in jail diversion programs haven't figured the problem, what gives?
Exactly.
That's really the question driving this research. Are we, past the point of effectiveness for diversion? Or are we maybe just missing a really crucial component in the overall system?
And our sources argue we are missing a massive component. So our mission today is to define it. We're using the framework of the Sequential Intercept Model, SIM, which sort of maps out every opportunity to intervene.
Right.
But the core insight seems to be that the success of every single one of those interventions relies on something entirely outside the police station or the courtroom.
Precisely. This deep dive is really about understanding that SIM framework and also why a truly comprehensive, robust community mental health system is, well, it's considered the ultimate intercept.
The ultimate intercept.
Yeah, the prevention mechanism that actually make all the other diversion efforts worthwhile.
Okay, let's unpack this. Let's start with the map itself, the SIM.
Okay, so the SIM. It's basically the leading approach for visualizing how we connect individuals with serious mental illness to community services instead of, jail.
Yeah.
The theory's pretty sound. The earlier you can intervene, the better the outcome.
For the person and the community, right?
That's
It sounds intuitive, but seeing it mapped out like this really clarifies where things might be breaking down. Can you walk us through those 6 intervention opportunities?
Sure. So we start with Intercept 0. This is key. It's pre-arrest. It focuses entirely on the crisis care continuum. Meaning the goal here is to avoid law enforcement contact altogether if possible. Think the 988 crisis line or maybe a mobile crisis unit showing up, clinicians responding instead of armed officers.
Okay, so alternative emergency responses.
Exactly. Stabilizing the situation without involving police. That's the ideal first step.
So someone's in crisis, a van with social workers arrives instead of a patrol car. That's Intercept 0, total bypass.
You got it. But, okay, if police involvement is necessary, then you move to Intercept 1. This is still pre-arrest, technically.
Still before booking.
Right. This involves specialized police responses. The most famous example is probably crisis intervention teams, CIT.
Yes. CIT, we hear a lot about that.
Yeah, these are officers with specialized training. They learn to de-escalate situations involving mental health crises, recognize the signs, and hopefully divert the person to a hospital or a treatment center instead of making an arrest.
Okay, so Intercept 0 and 1 are both trying to keep people out of the legal system entirely. But what if those fail and an arrest happens?
Well, that's when we enter the criminal legal system proper. And that brings us to Intercept 2, which is post-arrest.
Right after the arrest.
Yeah. This is the chance, right at booking or maybe during an initial court hearing, to identify that someone has mental health needs. It's about screening, basically.
Yeah.
Identifying who needs help within the system now.
Okay, so you identify the need. Then what? Where are they being held?
That leads to Intercept 3, which focuses on people who are actually incarcerated in jail. Here we're talking about connecting those individuals to mental health services inside the jail, or maybe diverting them to specialized court dockets.
Like mental health courts.
Exactly. Mental health courts are a big one. They supervise treatment plans instead of just imposing standard sentences. It's like a treatment contract managed by the court.
Makes sense. Okay, so after incarceration.
As the person completes their time, whether in jail or prison, we hit Intercept 4, re-entry. This is absolutely critical.
The transition back out.
Right. Facilitating a successful transition back into the community, making sure they have things lined up, housing, medication, appointments. It's about preventing that immediate cycle back into crisis or crime.
And then even once they're out, many are still under some kind of supervision.
That's the final formal intercept, Intercept 5, community corrections. This involves specialized probation or parole programs.
How are they specialized?
Well, they might have case managers who really understand the complexities of serious mental illness. The focus shifts more towards stability and recovery rather than just, catching technical violations.
Okay, so that's the 6 intercepts, 0 through 5.
But here's where the thinking really shifts and where our sources place the emphasis. The existence of these 6 intercepts, well, it implies there has to be a foundational system supporting them all. And that system is what's conceptually defined as the ultimate intercept.
Which is the robust, comprehensive, community-based mental health system itself. The system that ideally should have prevented the initial crisis, or at least kept someone stable after a previous diversion.
Precisely. That's the linchpin.
Okay, so if the SIM provides 6 distinct points to intervene, and, communities across the country have poured resources into these programs, CIT, mobile crisis, mental health courts, all of it, why are we still seeing this chronic overrepresentation? What's the disconnect? What's the policy debate here?
Well, it leads directly to what some researchers are calling the saturation point debate. It's a tricky argument.
Saturation point.
Yeah. The thinking goes something like this. Since the problem persists despite all these programs, maybe, just maybe, we've hit a kind of saturation point of effectiveness for these jail diversion efforts. A researcher named Henry Wasser has notably suggested this.
So the argument is basically, we've already diverted the quote-unquote easier cases, and now pouring more money into, say, another CIT team or a new mental health court isn't really moving the needle on the most complex cases.
That's the gist of it.
Yeah.
And that perspective, well, it suggests we should maybe stop allocating new resources to those specific intercept programs, intercepts 1 through 5.
And focus instead.
Focus instead purely on prevention way, way upstream, addressing the root causes like poverty, housing instability, the social determinants of health.
I see the logic in addressing root causes, but stopping funding for current diversion efforts, that feels like it could create a huge gap, couldn't it? What happens to people right now who are cycling through the system if you pull back on those supports?
That is the absolute core of the conflict. And the authors of our sources, while they strongly agree that we must address social determinants,
Of course.
they vehemently disagree that diversion programs have reached their full potential. They argue that abandoning these programs now, especially ones that show promise, would actually be devastating.
So their stance is?
Their stance is we need to keep funding and studying these diversion alternatives while, at the exact same time, seriously enhancing that ultimate intercept, the community system. Do both.
Okay, that sounds like a really tough balancing act, especially for, strapped local budgets. Fund prevention and sustain existing diversion. So if the programs themselves aren't necessarily flawed in concept, why are they so slow to show system-wide success? What are the hurdles?
It really comes down to implementation challenges and, frankly, fragility. First off, these programs constantly evolve. They're not static. Well, a CIT program might start, but then it takes years, maybe 5 years, to add a co-responder unit where a clinician rides with the officer, or to partner effectively with a mobile crisis service. A mental health court might start small and take years to stabilize before it can add crucial elements like, say, a forensic assertive community treatment team or FCT team.
So getting to full implementation just takes a long time.
A really long time. And these programs are effectively moving targets, always trying to optimize, which makes evaluation hard too.
Okay, what else?
The second major issue is just sustainment. Keeping these things going effectively is notoriously difficult. You're dealing with limited funding streams, constant leadership turnover across different agencies, police chiefs, clinic directors, judges.
Right, the key players change.
They do. And then you have competing demands. Think about when the opioid epidemic surged or when COVID hit. Resources and attention just got pulled away from these complex long-term mental health initiatives.
So those crucial partnerships, the ones between, say, the police department and the mental health center, they're inherently fragile. They depend so much on relationships, on trust that has to be built and nurtured over time.
Absolutely. Building that trust, having mutual understanding, clear procedures, that takes constant effort. Maintaining that partnership, you could argue, is often the hardest part, not the initial program design.
So it's often the administrative and relational burden that slows things down, not necessarily the core idea failing.
That seems to be a major factor, yes.
That sets up our shift in focus perfectly then. If intercepts 1 through 5 are fragile, need constant upkeep, and depend on strong partnerships, then we absolutely have to strengthen the place they're supposed to be sending people to.
Exactly.
The sources really hammer this point home. There's a line: diversion alternatives will not work if there is nowhere safe, stable, and high quality to divert people to.
That's the crux of it.
Yeah.
The ultimate intercept, the community mental health system has to be robust. But what does robust actually look like on the ground?
Good question.
Well, first, the clinical service array itself. It needs to be effective, obviously, but also accessible, culturally responsive, and, critically, it must be criminologically informed.
Criminologically informed, meaning mental health providers can't just treat the diagnosis in isolation. They need to understand the factors that actually lead to contact with the legal system.
Precisely. They need to understand risk factors for recidivism, for example. Second, that clinical system has to coordinate seamlessly with the whole social support services system.
Ah, the practical stuff.
Yeah, a successful diversion isn't just about therapy appointments. It means meeting basic human needs, safe housing, maybe vocational training, help with education, financial assistance. The clinical team can't stabilize someone's schizophrenia if they're also facing eviction.
Right. It's almost counterintuitive, but the sources frame diversion programs themselves when they successfully link people to intensive case management and social services as an approach to addressing those social determinants of health directly.
It is. It's forcing the system, however imperfectly, towards supporting recovery and stability instead of just defaulting to punishment.
Okay, so let's get specific. What actionable programs or resources do the authors say we need to pour into this ultimate intercept to really strengthen it?
They highlight a few key areas where resources are critically needed.
Lay them out for us.
Okay, first, proven models like housing first programs. Resources are desperately needed here.
Housing first. That's putting people into stable housing without preconditions like sobriety first, right?
Exactly. Stability first, then wrap services around them. It fundamentally changes the game for someone in crisis. It's foundational.
Makes sense. What's second?
Second, strong support for SR programs. That stands for Social Security, Disability, Insurance, Outreach, Access, and Recovery.
SR. Okay, what does that do?
It's an initiative specifically designed to help high-risk, really vulnerable individuals successfully apply for and get essential disability income benefits, like SSI or SSDI.
Why is that so critical for preventing legal involvement? It seems purely financial.
Because that financial instability is often the trigger. If a person with a severe mental illness has access to stable, consistent income, they're less likely to end up homeless, less likely to commit minor survival crimes, better able to afford medications, co-pays, transportation to appointments. It's a massive stabilizing factor, a financial lifeline.
Okay, housing first. SOR.
Yeah.
What's the third area? Improving the clinical system itself.
Yes, increased funding for models like certified community behavioral health clinics or CCBHCs.
CCBHCs, what makes them different from a standard clinic?
What's different is that CCBHCs are mandated to provide a comprehensive set of services. Things like 247 crisis response, routine screening for a wide range of issues, and importantly, coordinated care with hospitals, schools, primary care, the whole network. They aim to be a true single point of entry for accessible, high-quality care.
So really building out the infrastructure of community care.
Exactly. Now, building on that, there's a crucial paradigm shift the sources call for within the clinical mental health system itself.
Which is?
Recognizing that criminal legal system involvement itself acts as a kind of hidden social determinant of health. That's a really powerful way to think about it.
Hidden social determinant. Explain that a bit more.
It means a provider has to understand that having a criminal record, being on parole, having outstanding warrants, these things carry huge social consequences. They can mean denial of housing, inability to get certain jobs, even restrictions on where someone can live or travel.
So those legal pressures can impact a client's stability just as much as their symptoms or diagnosis.
Absolutely. Which means asking about criminal legal history needs to become as routine for a psychiatrist or a therapist as asking about psychiatric history or substance use.
Wow. So community mental health settings need to basically expect this involvement.
They should, yes. Just like they learned over the years to expect co-occurring substance use disorders alongside mental illness,
Yeah.
you have to ask about it, screen for it, and be prepared to address it proactively.
Which allows providers to maybe address criminogenic behaviors, things linked to crime within the community treatment setting before another crisis or arrest happens.
That's the goal. And importantly, this also demands a real equity focus. Treatment approaches have to address how mental illness intersects with race, ethnicity, poverty, and other marginalized statuses. And the system needs to actively work on addressing structural racism within mental health care itself.
That's a huge but necessary undertaking. Okay, so we have the map, the sim. We agree on the ultimate goal, strengthening that community ultimate intercept. And we even have some concrete pathways like supporting housing first, SOR, CCBHCs.
Right.
But we touched on this earlier. The evidence-based supporting specific jail diversion programs is often limited or kind of nuanced. Why is it so incredibly hard to definitively prove what works in this specific area? What are the research roadblocks?
Oh, the challenges are immense. They're both methodological, how you design the study, and just purely logistical, practical problems.
Like what?
Well, first, there's a massive issue of retention in research studies, trying to keep people enrolled long enough to see results.
Why is that so hard here?
Because you're dealing with a population that often has incredibly complex clinical needs, unstable housing, ongoing legal issues. They're often highly transient. It is just incredibly difficult to keep someone enrolled in a research study for the months or even years needed for a longitudinal design that proves long-term effectiveness.
Yeah, I can imagine. If someone's worried about where they're sleeping tonight, filling out a research survey is probably not top of mind.
Exactly right. Second, there's the challenge of tracking transition, following individuals as they move between these different intercepts.
Moving from police contact to jail, jail to court, court back to the community under parole.
Yes. The data systems often don't talk to each other. Health records are separate from court records, which are separate from jail records, which are separate from parole records. Trying to follow one person accurately through that fragmented system for research purposes is, well, nearly impossible sometimes.
Okay, retention and transition tracking. What else?
Third, there's the huge issue of local variability. What works brilliantly for a CIT program in a big city with lots of resources might completely fall flat in a rural county where the nearest mental health professional is 2 hours away, and the sheriff's department covers a massive area.
Right. Context matters hugely.
Hugely. Local practices, state laws, county funding streams, they all shape how these programs work on the ground. This makes it really hard to do multi-site comparisons and say, yes, this specific mental health court model is universally successful. You always have to add the caveat, well, it worked here under these specific circumstances.
You mentioned earlier that programs often get hastily implemented because the need is so great. Is the research community maybe asking too much, too soon, expecting perfect data collection from agencies that are already underfunded and just trying to handle crises day to day?
That's a really fair point. The pressure on communities to do something is enormous. So often, a program launches without a really solid long-term evaluation plan baked in from the start.
And then what happens?
Then, if it doesn't show immediate, dramatic, perfect results, which complex interventions rarely do decision makers or funders might get discouraged and move on to the next shiny new idea.
Meaning, potentially effective interventions might get abandoned before we even fully understand how they work best or how to optimize them.
Precisely. They might not get the time they need to mature or be studied properly.
So, given all these roadblocks, what kind of research do we actually need to move forward if we want to get beyond just anecdotal successes or small pilot studies?
We need high-quality implementation research studies that look closely at how programs are put into practice. We need robust program evaluation that uses the best available methods despite the challenges. And crucially, we need more systems-level outcome studies.
Systems level.
Yeah, moving beyond just asking, did this specific diversion program lower arrest rates for its participants? We need to ask bigger questions like, what combination of interventions works best for which specific groups of people under what kinds of circumstances to achieve broader goals like long-term housing stability, improved health outcomes, and sustained recovery? It's about understanding the whole picture.
What works for whom, under what circumstances? That seems to be the key phrase.
It really is. Hashtag Chai Outro.
So, wrapping this all up, what does this deep dive mean for you, whether you're a policymaker, a provider, or just someone interested in justice reform?
I think the core takeaway is really about a pivot in strategy.
Yeah, I agree.
The goal isn't necessarily to abandon promising diversion practices, things like CIT teams at Intercept 1 or specialized courts at Intercept 3, but it's about recognizing they're only ever going to be as strong as the community system that's supposed to receive the people they divert. That's it exactly. It means the success of the entire sequential intercept model, all 6 points, really hinges less on the specific police or court programs themselves and much more on achieving that ultimate intercept.
That robust community services system, effective, accessible, recovery-oriented.
Right. So the investment focus, the policy focus really needs to shift to upstream, bolstering access to those essentials. We talked about things like housing first, ensuring financial stability through SR, making sure high-quality clinical care through models like CCBHCs is actually available.
We've kind of moved past the initial goal of just keeping people out of jail cells for a night. Now the real focus has to be on creating a system strong enough to actually sustain their stability and support their recovery once they are back in the community.
And that shift in expectation really defines the challenge ahead. So maybe here's a final thought for you to mull over, something that builds on all this. Since that ultimate intercept, that community system, is defined by its ability to prevent recidivism and provide genuine stability.
What's the measurable, tangible difference?
Difference between what? Between a community that merely has a few decent diversion programs scattered around and a community that has achieved that deep level of comprehensive, coordinated support, the kind needed to truly sustain the recovery and stability of every single person diverted into its care. Figuring out how to measure that difference and how to achieve that higher level of sustained coordination. That's the critical question facing policymakers and stakeholders right now.